Good day, everyone. Hello? Is it morning? Okay. I am going to share some lessons from a South African project, which is monitoring and evaluating a new program called the NHI, or National Health Insurance Pilot Project. This project is done in 2 districts in South Africa. But in terms of budget monitoring and expenditure tracking, the work covers the national and provincial layers. So I hope there will be some good lessons. So the work that we have done basically is built on a practice that involves communities. So we have realized that the work that we do at national level has not really helped without bringing on board the people that are affected by the issues that we monitor. So we have done quite a lot of monitoring around the budget and expenditures, and we have found that South Africa is doing very well in terms of allocations and spending on HIV and AIDS. But there has been an outcry from the community level where people say, we don't get access to services, the services are not good enough, and what is this money doing for us? So we have been forced to come down to community level and say, let us work together. So the project basically tries to bridge the gap between community monitoring and budget monitoring so that whatever we do around budget advocacy, we can also incorporate the real issues that come from the ground. So this slide basically shows you what the South African government is spending. So currently, South Africa spends about 11.4% on health, and about 10% of that goes to HIV and AIDS. So we have seen that a lot of money in South Africa is actually being pushed towards HIV and AIDS, but communities are saying, well, we are not all infected, we are not all affected. We also want to see money going to other issues, such as chronic medications. So in terms of this monitoring, we have seen that patients that are accessing HIV and TB services are more satisfied with the quality of services they receive, but the rest of the community is not satisfied. So basically the issue is, are we making sure that we are putting the money in the right place? And if HIV is receiving all the money, what about the rest of the citizens? So basically we have learned to be neutral in what we say. We can't always fight for HIV budgets. We also need to look at the general health sector and see if this health sector can actually provide services for all, rather than just for HIV infected and affected. So this slide shows you that HIV in the next 2 years will be taking about 10% of the health budget, which is quite big when you look at other needs around health in South Africa. But then the issue is, are there enough people that are advocating for other things? Or is it only the HIV sector that is advocating for more resources for HIV? So we have learned that, as I've said, we can't just fight for HIV, we need to cover all issues that affect the population. So this slide basically shows you how fast the HIV budget has grown over the years. About 10 years ago, South Africa was spending about $100 million on HIV, but now it is spending about $1.2 billion on HIV, and this is supposed to grow in the next few years. And this excludes all the money that comes from donors. So you can imagine how big this budget is. But what is good is that we have seen that the government has built the capacity to absorb the money so that it's not just the budget for the sake of having the allocations, but they actually use the money, and we also monitor implementation to see if this money is actually bringing us any changes. So the National Health Insurance is quite new in South Africa. So the project that I'm presenting is a pilot. So we have realized that we need to make sure that we improve health services so that everyone can have good access to health care. And the best way that South Africa has seen is basically to introduce the National Health Insurance. But we know this is going to be very expensive and we do not have the money for it. So South Africa has decided to pilot implementation of the NHI, and we have said we want to monitor and see what is happening to this pilot so that we document the lessons and inform the further developments that are expected on this. So the pilot process started in 2012. And there have been some serious challenges and delays in spending the money that was allocated for this pilot. And provinces that are supposed to spend the money have identified a number of issues that blocked them from spending the money. So this has resulted in the National Treasury reducing the allocations for this pilot and basically shifting the money to the National Department of Health to support provinces with implementation. So basically, we say there is need to provide capacity at provincial level so that those who are piloting have got the capacity to pilot and generate good lessons for the whole country when we roll this out in full. So there are some issues that have been identified, and the main issue that we have faced is that our doctors are not willing to sign on this national health insurance because of the consultation fees that the government is offering. So if the doctors are not prepared to sign up for this, how can we make sure that we bring the best quality of service to everyone in South Africa? Because we do need the doctors. So some work needs to be done around the terms of reference as well as the consultation fees that the donors require. For example, one doctor said he makes about 1,000 rands per hour, but the government expects him to make only 300 rands per hour. So it's a big cut in terms of what they would benefit from the government. So there is need for negotiation to happen to make sure that we get the right people to implement this program. So because of this lack of capacity and other issues at provincial level, we have seen that the NHI or the grant that has been allocated for the pilot has been cut quite drastically. As you can see, the yellow bars on the slide show how big the budget has been cut. But at the same time, the money has been shifted to national government to make sure that the provincial government is given enough support to pilot. So at least the money is not lost. It is still there in the system. So there are some specific issues for service delivery. We have seen good collaboration between communities and government in terms of health workers as well as the health officials in the district and provincial government. We have seen how important it is to build the capacity of communities so that when they engage with government, they can speak the same language, and then government officials can give them the respect that they need. Because in the past, government officials used to ignore citizens because the language that they were speaking was not the language they understand, but also usually they did not have the facts in terms of the evidence. So this project has built a lot of capacity at community level so that communities themselves understand what a budget is and they know how to analyze the budget. And not just analyzing the budget, but also following expenditure. Because what we have learned is that in many cases, budgets are allocated, but nobody follows if the money was actually used. So we have found power in looking at the actual expenditure so that whatever was allocated was actually used. And if the money was not used, we want to know why. So if there are over expenditures, we need to understand why there is over expenditure. If there is under expenditure, we want to know why there is under expenditure so that we can actually try to look at the issues and try to resolve them. So the communities have absorbed that capacity, and it's quite interesting in terms of what happens at community level. So there are some good stories to tell from this work, but also there are still some challenges that this national health insurance pilot need to cover. For example, a lot of places, especially in rural areas, they still complain about shortage of staff, of health workers, which is the biggest problem in health service delivery in South Africa. And also some areas are still talking about drug stockouts. So we know that with the NHI, if it is well implemented, all those issues will be addressed. But then who is monitoring to make sure that these issues are identified? And that's where the community has come up. But also issues around governance. When you look at health facilities and at the district hospitals, you find that nobody has been prepared to provide answers when communities are asking questions. But there are some governance structures, the clinic committees and the hospital boards, that are supposed to provide oversight in terms of what these facilities are providing. So we have realized that we also need to build the capacity of these structures, even though we are civil society organizations, but they need our support as well so that they know what is expected from them, so that when we demand, they can actually answer to our demands. So basically, that also has built a good relationship between civil society and these structures because they know there is something they are benefiting out of the relationships. Okay, so moving forward, we know that most of the problems that we have will not be solved by the NHI pilot or by the NHI grant that has been allocated. We know a lot of money has been allocated to the health sector in general, and there's quite a lot of money allocated specifically to HIV, but there's also a lot of money allocated by donors. So we know that it's not always about the money. We need to understand what are the blockages in the systems that we can actually fix so that we can provide the best quality of services. So in terms of monitoring of the budget, we say we need to ensure that there is sufficient resources for health in general, because if we only focus on HIV, we run a risk of having a lot of money going to HIV while the other programs are suffering. But we have also seen a lot of shifts in terms of staff. Some people have seen that HIV programs are quite sexy and people are leaving their jobs to actually move to HIV programs. Then what happens to the general health service provision if everyone wants to do HIV work? And also in terms of governance that we've identified, we need to build capacity in governance, because if we do not have good governance in our health system, then it means whatever we fight for will never be addressed. So at the end of the day, we need to have people that we can hold accountable at community level, at district level, because we have realized that targeting people at national level does not usually help. So it helps to target people that are closer to us, so that if they need support for national advocacy, we can actually support them to do that. And this project has actually assisted us to work closer with clinic managers, because they have realized that we have the power to push them in terms of engaging with their national counterparts. So we have developed a partnership with clinic managers and hospital boards to actually advocate at district and national level. So it's a nice partnership that nobody thought of. So at the end of the day, everybody is benefiting from the projects. But also it is important that we keep monitoring, because if no one is monitoring, then we run a risk that no one will deliver. So it is our responsibility to keep watching what is happening, not just to the money, but to policy development, implementation, and also to actually see if we can also do some impact assessments, because it doesn't help us to be excited about the money. We need to see if the money is bringing about any change. Thank you very much.